Yes. We'll give people another couple of moments to get connected. We are so glad that you've joined us today for our webinar on preventing exploitation and substance use in adolescence. A little bit of housekeeping before we begin. All attendees for today's session are in listen-only mode. If you'd like to ask a question during the session, you can do that by using the Q&A icon that should appear on your Zoom control panel. If you'd like to share ideas, you can do that using the chat function. To turn on closed captioning, click on the CC button. We'll ask that you complete a handful of brief evaluation polls at the end of the session. Today's session is being recorded. We'll share it in a follow-up email, and it will be posted online. We had planned to have live Spanish interpretation at today's webinar, but due to a technical issue on our end, that will not be possible. However, our Spanish interpreters will record the session in Spanish, and we will share that out with you following today's session. To our Spanish interpreters, would you like to share that in Spanish?
Thank you, Emily. And hi, everyone. This is Andrea, and I will be sharing this message in Spanish. ¿Qué tal? Buenas tardes a todos. Bienvenidos a esta sesión. Queremos avisarles que debido a una falla técnica con la opción de interpretación simultánea de Zoom, no vamos a poder ofrecerlo en vivo, pero vamos a grabar la sesión y después proporcionaremos la grabación en español junto con la presentación en PowerPoint. La recibirán en sus correos electrónicos y de nuevo una disculpa por debido a esta falla técnica. Ok, gracias and back to you, Emily.
Thank you, Andrea. We also have 2 ASL interpreters who should be spotlighted on your screen. Our learning objectives for today. We hope that by the end of this webinar, participants will be able to explain the connection between adolescent substance use and exploitation and relationship abuse, and that you'll be able to identify several strategies to promote healthy relationships, reduce risk for substance use, and prevent abuse and exploitation. We want to acknowledge that many of you submitted questions when you registered, which we're so grateful for. Some of them we will answer today. Others we may not get to, but we'll provide some resources to help you learn more about those topics. I'm so excited to be joined and partnering with our colleagues at Health Partners on IPV and exploitation. Jake?
Yeah, thanks, Emily. So just to introduce Health Partners on IPV and Exploitation, we are an NTAP project led by Futures Without Violence and funded by HRSA's Bureau of Primary Healthcare. Our expertise is in intimate partner violence, exploitation, human trafficking, and bolstering prevention efforts for these issues by working with health centers and health center staff to support those victims, survivors, and people at risk through free educational programs like webinars in our YouTube archives, small group trainings, and other tools.
Thank you, Jake. And I'm at the National School-Based Health Alliance. For the past 30 years, we have worked to increase children's access to healthcare through school-based healthcare. Much like Health Partners, we are an NTAP, and we offer resources to health centers to support their work as it relates to school-age children. I'm Emily Baldy. I'm a senior manager at the National School-Based Health Alliance, and I'm so happy to be joined today by Dr. Miller and my colleague Jake. Dr. Miller and Jake, would each of you like to introduce yourselves briefly?
Sure, I can go first. Oh, actually, go with
Perfect.
Dr.
Oh, perfect. Sorry, I was finding my unmute button. Good morning. And actually, it's good morning my time. And good afternoon to all of you. Thank you so much for joining us. I'm Liz Miller. I'm a physician in adolescent and young adult medicine and a professor of pediatrics. My primary area of research has been with adolescents and young people and understanding relationship abuse and exploitation and the impact on adolescent health, as well as interventions to promote adolescent health and safety. Jake.
Thanks. I'm Jake Sessa. My background's in public health, and I'm a program associate at Health Partners on IPV and Exploitation. And the NTAP project, Health Partners on IPV, is one of my primary projects. Thanks.
Thanks, Jake. We also have two fabulous guest presenters from the Support Center for Child Advocates, Liz and Diamond, and each of them will share a little bit more about themselves and their work in a couple of moments. But for now, I'm going to turn it back over to Dr. Miller to talk to us a little bit about exploitation, relationship abuse, substance use, and adolescent development.
Perfect, Emily. Thank you. And a real privilege to be here with you all today. I'm going to take the first 10 minutes or so to just set the stage for us in terms of a reminder about the really deep intersections of substance use with both relationship abuse as well as exploitation and the profound impact it has on adolescent development. And like Emily, I want to echo my appreciation for the many questions that came through prior to this webinar. And I saw lots of questions about substance use prevention. And I think what I would like as my personal goal for this webinar is to have you all include recognition that relationship abuse, exploitation, all contribute to the use of substances in adolescence, including substance use disorders. And with that, next slide. Just a reminder about how common teen dating violence, also called adolescent relationship abuse, is for young people, affecting millions of young people each year. And we find through a national survey that has been conducted by the Centers for Disease Control and Prevention that about 1 in 5 girls and 1 in 11 boys in high school have been physically and or sexually victimized by a dating partner. And so we also know that dating violence can begin very early in middle school and often occurs in college age relationships as well. So this number is likely significantly higher. So next slide. When we talk about unhealthy relationship behaviors or relationship abuse, it includes ways of sort of thinking about this in terms of terminology, in terms of domestic and sexual violence, or and the point here is what makes it relationship abuse. This is a pattern of methods and tactics specifically to maintain power and control. And abusers may use jealousy and social status and mental health, money, technology, but also substances and other tactics to be controlling and abusive. And sleep disruption and substance use coercion, you can go ahead and click through, and physical abuse are not uncommon strategies used by people who use violence and exploit others. And next slide on human trafficking is a reminder that when we talk about human trafficking, this is really divided into labor trafficking as well as severe forms of sex trafficking and a commercial sex act induced by force, fraud, or coercion. And I suspect that many of you on this webinar are already familiar with the fact that a person induced to perform such an act who has not attained 18 years of age, meaning a minor, does not necessarily have to have force, fraud, or coercion to be considered sex trafficking. Next slide. So As those of us who have been in the field working to prevent sexual violence and intimate partner violence, we tend to use much, much broader definitions than the legal definitions of human trafficking and severe forms of sex trafficking. So this is just a reminder that as we talk, we're talking broadly about preventing and intervening in sexual violence, which can include a whole range of behaviors that cause harm. And then within that, of course, sexual exploitation and sex trafficking. Next slide. What is so interesting for me over the years of doing this work is the extent to which we continue to silo relationship abuse in one place and human trafficking in another. And yet, my clinical experiences, as well as research, has shown that there are many shared dynamics. And please click on through. This can include physical and sexual violence, restrictions on freedom of movement and control, isolation, financial control, intimidation, fear, and certainly the coerced use of substances, including alcohol and other substances. And what gets really complicated for young people is that the person harming them can be a romantic partner, family member, caregiver, or someone in their social network that is causing and engaging in exploitative behaviors. So I thought that as many of you are providing clinical care and or working on the front lines supporting young people, that we ought to include a case study to just remind us that we're talking about the really, really precious young people we have the privilege of serving. And so this is just a story about a 16-year-old named Daniela, who you saw last week at your school health center for concern for STIs. Today, she's back to review her results, all of which are negative. When asked how she's doing this week, she says she's so tired, and today she has a bad headache and she wants something for her headache. You remember that she complained about a headache last week as well and asked about her sleep, which she says not good, and says her boyfriend keeps her up at night. You ask, can you tell me more about that? To which she responds, not really. You know that Daniela loves drawing and has found joy in her art classes. You ask if her being so tired and the headaches are making it hard for her to do her artwork. She shrugs. You offer her some information about strategies to get more sleep, as well as offer her a healthy relationships card that you recently learned about on a webinar about relationship abuse and exploitation. You congratulate her on coming in today to review her results and to share more about the headaches. You ask her if she's willing to check back in next week to see if any of the information you offered was helpful. So let's keep Daniela in mind as I go through a few more of these slides. So what we know in terms of health issues, one, the reason that we really focus on health centers as a place to address adolescent relationship abuse and exploitation is because we know that the prevalence of relationship abuse is significantly higher in clinical settings. And that is because of the health issues that lead to encounters with healthcare. So young people experiencing abuse and exploitation may come in certainly for emergent medical conditions and severe wound infections. And also coming into our school health centers, right, are for gynecological services, including STIs, could be late or no prenatal care, substance use concerns, mental health conditions, certainly somatizing concerns of mental distress, whether headaches, stomach aches, fatigue, dizziness, dental emergencies, as well as musculoskeletal pain and injuries. Next slide. So we also know that traffickers very specifically target young people who are dependent or addicted to illicit or prescription drugs. And substance use coercion is not uncommon as a method for maintaining control. And by specifically substance use coercion is the use of substances to maintain power and control in the relationship. And we really, I think, as a group of folks so committed to caring for young people, need to establish standards of non-judgmental, patient-directed care. And again, specifically highlighting substance use coercion because this is much more common than previously understood. Traffickers often introduce victims to illicit substances or use existing drug or alcohol addiction to force them into exploitative circumstances. And we certainly know from studies that drugs and alcohol were commonly used by individual traffickers and very commonly by gang organized traffickers to control their victims. So, next slide, underscoring again that health programs are so essential for doing this work is that in my clinical experience, I have not had a young person waltz into my clinic to say, hello, I'm in a I'm in an abusive relationship, Dr. Liz, and I need help. Yet we know that relationship abuse and exploitation are very common among adolescents seeking clinical services. The prevalence is significantly higher than the general population. And what we know in terms of the adolescent clinic-based samples, lifetime prevalence for relationship abuse is 1.5 to 2 times more than the population-based estimates. And in some of our studies, we have found about 1 in 2 young people having had an experience of relationship abuse. And we also know that prevalence estimates for human trafficking and exploitation are much more challenging to obtain, including youth engaging in survival sex, as well as the overlap with relationship abuse. So one of the things that we want to emphasize, and you're going to hear much more from Liz and Diamond in a moment, is that why I want us to all consider the many reasons that a young person might not come into our clinical spaces prepared to disclose or interested in disclosing what they're experiencing. And that includes judgment, lack of recognition that those behaviors are abusive and controlling, certainly fear of child welfare involvement and police involvement, not knowing what people are going to do with that information, certainly not trusting that we know how to protect that information. If someone is controlling or exploiting them, they may be very fearful about retaliation, as well as lack of awareness of their own rights. And there are probably other reasons that you all are thinking about for a young person choosing not to disclose. And so part of what I want to conclude my time with is just sharing with you one intervention, one resource, which is on the next slide, which is called CUES. And this is a universal education intervention which focuses on reducing a young person's sense of isolation and increasing their options for safety. This approach of universal education, offering information regardless of disclosure, has been evaluated in multiple clinical settings and found to increase a young person's awareness of what sexual coercion, relationship abuse is. It increases their knowledge of resources that are available. It increases their self-efficacy, meaning their confidence to actually use those resources, which are the goal of a universal education approach. The CUES intervention, that mnemonic is C for confidentiality. Always have these conversations in private and discuss the limits of confidentiality up front. U for universal education, provide healthy relationship education to all of your young people. And remember to offer the information saying, this may not be immediately relevant for you, and I suspect that you know somebody who could use this information. Can I count on you to take this information to share with others? And that adding that little bit of please share this information with others, we have found really taps into the generosity and altruism that are such strengths of the young people we serve. And then finally, and Emily and Jake will discuss a little bit more towards the end of the webinar, the importance of support, offering continuous support as well as access to resources to ensure that teens make healthy choices and seek help. And so with that, it is my absolute pleasure to turn this over to Liz and Diamond to share their expertise with us. Thank you.
Thank you, Liz. My name is Liz Stein. I am the Human Trafficking Specialist at Support Center for Child Advocates in Philadelphia. We are a nonprofit law firm that works with survivors of human trafficking, and I am joined today by one of our Youth Survivor Advisory Board members, Diamond Thompson, and she's going to give us some insight in a couple minutes as to what her experiences have been when she has interacted with healthcare providers. Next slide, please. Thank you. So a little bit about Support Center for Child Advocates, Project Protect, and what we do. Our office convenes the Philadelphia Juvenile Anti-Trafficking Coalition, which is now a subcommittee of the larger Philadelphia Anti-Trafficking Coalition. And in the juvenile subcommittee, we have over 143 members from 50 organizations across the Philadelphia area. Our coalition felt very strongly that they needed to be informed by the voices of lived experience. So one of the first things that they did was they instituted a youth survivor advisory board to give insight and recommendations as to procedures and policies regarding human trafficking survivors. We create tangible and usable resources like a red flag infographic, a screening tool, a social services directory for Philadelphia area. We also convene the Juvenile Anti-Trafficking Summit in Philadelphia, and that brings community members together with people who have lived experience in human trafficking along with professionals. And between 2022 and 2025, we conducted trainings for more than 1,000 people in various aspects of human trafficking. Next slide. So who's at the table in our Philadelphia Juvenile Anti-Trafficking Coalition? And why am I telling you all of this? It will make a lot of sense in a couple of minutes. So we have at the table our Child Advocacy Center. We have behavioral health providers, probation, school district counselors, youth homelessness service organizations, the FBI, family court. We are fortunate in Philadelphia to have an anti-trafficking courtroom in Philadelphia. We bring our Youth Survivor Advisory Board members, and I'll talk about them more in a minute. And children's hospitals, Children's Hospital of Philadelphia and St. Christopher's. We're going to talk more about this in a minute. Children's Hospital has something called the Adolescent Protective Collaborative, and that is a clinic for young people who have either experienced human trafficking or at high risk of human trafficking. And it really focuses on reestablishing medical care with them and continuing to offer them medical services throughout their journey. We also have therapists, public defenders, other medical professionals, child welfare professionals, case managers, attorneys, and our local Salvation Army New Day to Stop Trafficking program. Next slide. So what is the structure of our board? So we currently have 4 young people on our board. We have the capacity to have up to 8 survivors of human trafficking who are between the ages of 18 and 26. We recruit on a 6-month cycle, and we do not ever ask anyone to leave once they have joined. But we think that giving a young person a cycle of 6 months is something that they can commit to, and they are welcome to, remain with us for as long as until they age out, actually. We compensate them for their time and labor, and we also remove other barriers to them working with us, such as things like we pay for childcare, we pay for Lyft rides to and from events in our offices. They have an initial orientation period. It is completely voluntary that they participate. If they join our board and they don't feel like the work is for them, we absolutely respect if they need to step away. And we have monthly board meetings and coalition meetings. Our young people developed a training for other young people, and they're presenting that across the city. They do speaking engagements like Diamond joining me here today. We do team building activities and we have social events. And I serve as the survivor mentor for emotional support. In addition to being the human trafficking specialist at Support Center, I'm also a survivor of human trafficking. And there are a lot of things that we are able to say to each other as survivors that maybe other professionals can't say, and things that need to be said. Next slide. So what does support look like for a survivor of human trafficking? I think that it's important for us to realize that between 70 to 88% of survivors have had contact with a healthcare provider while they were being exploited. I can tell you that during my exploitation and for years after, I was a frequent consumer of healthcare, and I saw many, many doctors who really genuinely wanted to try and help me, but they didn't know what was wrong with me. And that was a barrier to them treating me. And I want us to remember that support is more than just medical treatment. It's about respecting the autonomy of the person, and you need to build physical and psychological safety with survivors. We are so used to our worlds being turned upside down. We never know who we can trust, who we can't trust, and that is very dysregulating for us. So anything that you can do to build a relationship with a survivor and make them more comfortable interacting with you will go a long way for you. Next slide. What are some of the best practices? What things can you employ when you are interacting with human trafficking survivors? Consent. I know that this may seem like an obvious thing to bring up. If someone's in your office, they're there because they need medical treatment, right? But for survivors, it can be a really threatening environment. And so asking for their permission before you do anything, asking them if they're comfortable with what you're going to be doing will go a long way in building their trust. Transparency, explaining what you're going to do step by step. And I know that that might feel counterintuitive. It's like, well, why do I have to tell them that I'm going to touch their arm now? And we as survivors, we really just don't ever know how people are going to treat us. And so if you're able to tell us step by step what you're going to be able to do, we'll know what to anticipate and we won't have fear around it. Our words really matter when we're talking. We need to focus on the safety and the needs of survivors and avoid probing or judgmental questioning. And instead of saying, what's wrong with you, we need to step back and kind of say, well, what's happened to you? Why are you exhibiting these symptoms? Why are you in so much distress? We get a lot of judgment as survivors, and nothing will make us clam up quicker than when we feel like we're being judged. Building trust is so important. You can build trust with people in little ways, remembering their name or something personal about themselves, or even if this is someone that you're seeing for the first time and you know that you won't see again, just taking a second to connect with them on a human level will really help them feel more comfortable and let them know that you're invested in their care. Offering kindness and following through on what you say that you're going to do will help build a relationship that's based on trust. We don't know who we can trust. And so anything that you can do to signal to us or let us know that you're someone that we can trust will help us get through the medical exam. Next slide. Next slide. Connecting survivors to services. Warm handoffs. So one of the reasons that I told you about all of the people who are at the table in the Philadelphia Juvenile Anti-Trafficking Coalition is because we can't do this work alone. We can't do it in silos. And the more people that we know in our community, the more we can help trafficking survivors. And so it's important to remember that these young people are scared. They might not understand how to follow up with another physician. And so if you know someone personally and you can make a warm handoff, that young person has a 50% chance of following through more than they would have if you had not. And so when you give warm handoffs to providers, it communicates that you are invested in their care and that this is really important to survivors because we experience chronic abandonment. People who come into our lives and say that they're going to come and they're going to help us, and they give us a lot of promises, but they don't follow up on them. And so we don't know who we can trust. And so anything that you can do to assure a survivor that you're trustworthy will go a long way with them. And I just talked about how important it is to build networks with other service providers in your community. If you're fulfilling the medical piece, who can help with the survivor's other needs? Do they have housing needs? Do they have a desire to pursue education? Are they looking for a job? We really want to look at the whole person because recovering from trafficking takes a lot of effort. When you are being trafficked, you are taken out of society for that period of time in which you're being trafficked. You're taken away from your education. You're taken away from professional opportunities. And your sense of trust and well-being is disseminated during the trafficking experience. And you exit and you really don't have anything other than your dreams. And you need people to help you to get to your dreams. We want to make sure that we're respecting survivors' autonomy. We want to give them options, not orders. Asking, would you like me to connect you now? Or do you want the information so you can do it later? And sometimes it helps if you have the capacity, and I realize in a healthcare setting, you might not always have the capacity to sit down and make phone calls. But if you can pick up the phone with that young person and introduce them by name, that will go a long way in making them feel comfortable in following up with these other providers that you're referring them to. Next slide. Why our words matter. Survivors are really intuitive. We're always reading the room. We're reading people's facial expressions, what their tone of voice is, what they're doing with their hands, what their eyes look like. We're constantly scanning for safety. And so if you're using affirming words, things like, you deserve care, this is not your fault, you're not in trouble for what happened to you, and you're in control of what happens here. In the trafficking experience, we don't have any control over what's happening to us. And so we don't want to replicate the things that happen to us during trafficking in medical settings. We also want to remember that we can't use deficit-based terms. I have heard from a lot of survivors that when they went for medical care, that the provider would say, are you prostituting yourself? Are you a prostitute? And that's not really an accurate description of what's going on for this young person. And that will immediately put a young person on the defensive because of the negative connotation. And as Dr. Liz said earlier, a child under the age of 18 cannot consent to commercial sex. And so it is automatically human trafficking in these situations. And so when you are talking to these young people, the words that you use and the way that you approach can determine whether we feel safe or we feel threatened. And we don't want pity. We are not looking for anyone to treat us like we're China dolls, but we need honesty and transparency. We need to know what to expect, and we need to not be othered. We need to be treated as whole people. And we need medical providers in our lives who see that we're more than what we're just presenting with in the clinic this day. Next slide. Privacy and environment. So when we walk into medical offices that have information on the walls, have pamphlets, places that are comfortable to lighting that is not too bright, all of these things can help someone feel more comfortable in a clinical setting. We need to remember that safety is not only physical, but it's also emotional. And so for our physical safety, taking us into a private exam room, not speaking when other people are around, making sure that the spaces are secure, having affirming visuals on the walls and respectful tone. I think that it's important for us to remember that a lot of times a trafficker will accompany a young person to their medical appointments, and they do that to intimidate the young person. They do that to control what information the young person is giving to the medical provider. And so you should always set a boundary that the young person is the only one that's allowed into the exam room. If you need to separate them from the person who seems to be controlling them, an easy thing to do is say, I need you to do a urine test and take them into another room. And it's also important to remember that these young people may be coming in not with traffickers, but potentially with their parents, and potentially with parents who don't know what's going on with them because they don't feel like they can talk to their parents. And so you may have an opportunity for a young person to disclose to you what's going on with them that they can't tell other people. And so it's really important that they have the space to do that in a private and confidential way. Also, you may be working with a survivor who will not disclose to you that they have been a victim of human trafficking for many reasons, fear, and also they may not understand what trafficking is. I say quite frequently that I was trafficked when I was a senior in college for 3 years. But I did not know I was trafficked until 2.5 decades later when my traffickers were arrested. So it's going to be a really rare occasion where someone comes in and says, I'm being trafficked, because it's really hard to wrap your head around what's going on with you. And I had to learn as a 50-something-year-old woman what trafficking was before I could identify. We also want to remember that privacy is a safety measure for survivors. It's not a courtesy. I said earlier, traffickers often accompany to intimidate and to control what is disclosed and to whom. And one-on-one time with your patient will allow the survivor to feel more comfortable and form a relationship with you and potentially disclose things that are going on with them that they can't disclose to anyone else. Next slide. So now we're going to talk about missed opportunities and lessons learned. I like this quote: every encounter is a chance to notice, validate, and connect. Even if disclosure doesn't occur, the interaction can still build a sense of worth and agency for the survivor. So I'm going to ask Diamond to talk about some of her experiences now. And she's going to first, Diamond, why don't you talk about your experiences when you're interacting with urgent care providers and what that looked like for you? And then go on to talk about what it looked like for you to go to the APC at CHOP and how that was a different experience. So I'll let you take it away.
Hi, my name is Diamond Thompson. I am a survivor. My experience with social workers and just DHS in general, I've been in DHS since I was about 6 years old, and I still am with DHS. I am 20 years old. I will be 21 next year. Being sex trafficked from the age of between 15 and I would say it stopped at 15 to 16, almost turning 17. And I didn't really know what sex trafficking was until I got older. It wasn't really explained to me the way that I know what it is now, now that I'm an adult. DHS wasn't there for me. They didn't get me the support that I needed. No therapy, just nothing. They just let it be, and they just kept continuing to place me in other group homes and other settings without getting the additional help that I needed as a child. It still bothers me, but I'm getting the help for it now. Only because I'm now getting the help. I'm making it happen. Now from having certain doctors and certain care, it was very hard for me. I never really had good doctors in my past. I never really had good nurses or anything like that to break stuff down to me, certain stuff down to me about my body and the stuff that I have encountered and caught. CHOP Clinic was the first place to make me feel welcomed and made me feel comfort and not feel judgmental. I was with them from 16 all the way up until I was about 18 years old. They always would sit down with me and ask me how I'm doing. It was never always about medical stuff or about running tests. They always made sure that my mental was okay, and they gave me certain resources when it came to food and therapy and doing other activities outside of school and just outside of home. And that kind of changed me around that time because I was in a very depressed stage, and it really helped a lot. So with that being said, I just would like to say CHOP is definitely a good place for younger youth. Now I couldn't continue to stay with them once I turned 18 because once you're over the age of 18, you can no longer stay with them. They sometimes do still contact me and ask about my whereabouts and how I've been doing with school and stuff like that, which is very appreciated. Far as interacting with certain social workers and stuff like that, COA, DHS workers, even down to family court judges. I've had not very good few social workers. Most of the social workers I've had never cared, never took consideration, never did anything for me, to be honest. I've only had one social worker that had cared for me, but she couldn't stay. So it's basically hard having a social worker that cares about younger youth and just younger kids that have been sex trafficked, abused, and mistreated.
Thanks, Diamond. I think that that's an important point to make, when youth who are being trafficked age out at 18, it's hard because they lose access to a lot of these services. But I appreciate that you shared with us interaction with the APC at CHOP really made you feel empowered and cared for. And so thank you for that.
Mhm. Oh, I can continue.
If you'd like.
Yeah. I would say the most major things I've dealt with in my life were one which was recently I got attacked, and that caused me to have something that I had to live with for the rest of my life. I told my judge, my coworker, I didn't give him detail, but I told him what basically kind of happened, and they didn't do anything. I still go to court once a month. My coworker still sees me once a month. They still had me in the same apartment that I am currently with Delta, which is not too far where I was attacked. They still have me here. So it's stuff like that that they don't take consideration on far as my safety and my whereabouts and if I'm comfortable or not. Honestly, in my opinion, I feel like certain social workers don't really care about the children. They care about the pay. They care about what's going to benefit them. They're not caring about none of the children, nobody. So I feel like, in my opinion, people need to do better, and they need to hire better people that are willing to make a change, and not even just young children lives, but older youth as well, because it's like there's so many older youth that sign themselves out soon as 18 come, because DHS scares a lot of younger youth. And honestly, truth be told, yes, I don't want to be with DHS. I don't, but I have to rely on DHS because I don't have no help. So it's like, it's either DHS or homeless. And it's like, I have to stick with DHS, sadly, to get the resources that I need. And I have to fight for them. They're not given to me. They're not, it's certain resources I didn't even know I could even get due to my social work. They're not explaining that to me. So it's like, it breaks down a lot in the system for as like not letting us know certain resources and helping us. Like Liz said, it's not that hard to really sit down with somebody and help them, make a phone call. You don't even have to sit with them in person. You can add them to the three-way call, help them make certain appointments that they don't know how to make, or, just guide them throughout the way and just help. Honestly, truth be told, I feel like that is something that I would appreciate a social worker if they did that. And that's like overlooked. I feel like they think just because they email it to us or send it to our phone, we're just supposed to automatically get up and go do it. I'm sometimes scared to make my own appointments, but I had to because I'm an adult and I have to get it done. I'm sometimes scared to go to an interview by myself or to go somewhere far by myself. I'm very scared, and it's like I do let my social workers know that, and they just bypass it. Oh, well, I can't do that. That's not my job. And it's like, I've had some social workers that came with me. I've had some social workers that just lie and say, "Oh, I can't." And that's what makes me very upset, is that you rather lie to me, knowing that I already know, or even if I didn't know, the fact that you just don't care enough to really even want. You don't even have to come. You can't just be on the phone with me and just guide me through it, like stuff like that. A lot of social workers need to take more care into their work instead of like just not caring about the child's well-being or the older youth well-being. Like, it's just a lot of that is just the issue in the system nowadays, sad to say. But it's a lot. I can go on and on and on and on, but I'm not gonna dive deep into everything I've been through in my life. But I do have a very long story to tell, and one day if I could write a book about it, I will. If I could make a movie, a show, or something out of it, I would.
You will.
So,
Simon, thank you so much for sharing about your experience. And one of the things that really came through to me was this idea of like one, really caring about the young people you serve and also being able to connect them. I think one of the things you said at CHOP was like it wasn't always about medical. It was also about like how are you and what do you need? And so I wonder if this is an okay time to turn it to Jake to talk a little bit about some of those action steps or things that providers can do, Diamond, in line with what you shared that did make a difference for you.
Thank you.
Yeah, I just want to further my thanks to both Liz and Diamond for sharing both your stories and your expertise about trust, about um, your experiences with services, and a lot of that overlaps with what I'm going to say. So I'm just going to quickly rush through these action steps. If we can go to the next slide. Um, So issues like trafficking are what we in public health call wicked problems. There's no one answer or magic pill or policy that's going to solve them. Unfortunately, it is that invasive. It's affecting multiple people's lives or multiple levels of society that we live in. Um, but it also means there are multiple levels that we can intervene on, and we saw this in Liz and Diamond's presentation. Um, we saw that Liz was talking about the all the facets of the Juvenile Anti-Trafficking Coalition, and it was made up of so many different partners that tackled issues that can prevent trafficking. And this chart really just shows some of those protective factors that can come from some of those partners, whether it's um, stability in state in their living environment or increased networks or access to services. These are all important protective factors for preventing the negative effects of trafficking. Next slide, please. And just expanding upon that part to increase these protective factors. Um, the easiest way to do this as a health center is through forming these community partnerships that expand the basic needs support, these resources that help adolescents thrive, that help them live, help them stay off the street, and help them be less vulnerable to trafficking. And partnering with any of the types of organizations that are on this slide is one way to reduce the risk and reduce the targeting of these youth. Um, Next slide, please. One shortcut to doing this is partnering specifically with domestic and sexual violence programs, um, because they are already so connected to services, either providing them themselves or through trusted partners. Services like safety planning, getting folks housing, children's services, employment, economic supports. That's going to once again um, stabilize the environment around potential trafficking targets and make them less likely to be trafficked as well. Next slide, please. And legal programs in general, partnering with them on the individual level, they are some of the most important partners for preventing HT because of the wide variety of aid that they can provide, whether it's public benefits eligibility, ensuring safe housing, food benefits. Next slide, please. And they have a storied partnership with school-based health and other adolescent groups as well. Legal partnerships with medicine have been were rooted at first in caring for adolescents and lawyers employed in legal aid programs that are partnered with school-based health can provide these services to help stabilize students and families, whether it's their housing or their need for healthcare, food assistance, identifying vulnerability in students in school-based health programs through uh, non-medical drivers of health screenings can help provide for these the lack of basic needs that make people vulnerable to exploitation. Next slide, please. And really, this is the heart of the model. It's ultimately building that trust. Diamond mentioned earlier that um, survivors have a hard time trusting folks, trusting systems that ultimately have failed them. So if you can be the touch point for um, these adolescents to build trust and gain trust in these systems so that they can know that they can fall back on them, so that they can get the support and resources that they need rather than making those hard decisions. It takes one less decision off their plate and steers them away from trafficking, from vulnerability. And thank you for going to the next slide. These are just some of the additional partnership benefits, including support for both not just the patients of a health center, but for the staff who may have experienced HT. Um, like Liz said earlier, establishing regular care through re-enrollment is also so important for trafficking survivors because it provides more opportunities, not just for health and access to resources, but for touches for the healthcare providers to recognize trafficking as well. And then also emergency preparedness collaboration is important as well as disasters and emergencies also often um, cause spikes in trafficking activity. And next slide, please. And if we can go one more. Just very quickly, the Take It Down Act is uh, a law that was passed in May 2025. It expands upon the reauthorization of the VAWA Act that was focused on revenge porn, and there's just so many new ways that traffickers and exploiters want to control or coerce people, and one of them is through deepfakes, online deepfakes, especially when kids and adolescents are so focused on um, social media and the internet. The Take It Down Act, which requires platforms to remove pictures that are posted non-consensually within 48 hours, or to make it illegal to coerce using these deepfakes. This is a very important law to know for protecting kids. And now I will pass it to Emily.
Thanks, Jake. I wonder, could one of my colleagues I have a couple links in the chat for this slide. I will not spend very much time here, but if you work in a school-based health center and you're interested in how you might support students who are using substances, particularly around keeping them in school and engaged, we're going to share some resources both on screening, brief intervention, and referral to treatment, which will have some information about alternatives to suspension, and a recent webinar that focused on vaping. So not going to talk very much, but we'll drop those links in the chat and we'll share them in follow-up. At the School-Based Health Alliance, at Support Center for Youth, at other places, Support Center for Child Advocates, excuse me. We work to partner with young people. Again, if it's possible to drop the link for this slide, you're the best. Thank you, Anna, into the chat. If you'd like to learn more about partnering with young people, our resource Lead the Way might be a good option for you. I want to be mindful of our time. These resources will be shared in follow-up. Andrea, if you could launch the Zoom poll while we express some gratitude. Thank you so very much to Liz and Diamond for sharing your experience, your insight, your expertise. It was great to read in the chat how impactful that was for participants. And many thanks to our interpreters today. We're so appreciative of you being here. And then from us at School-Based Health Alliance, so much gratitude for Futures Without Violence and their continued partnership. Jake, Anna, Liz, Diamond, anything else to say as we close out?
Nothing. I just want to once again reiterate my thanks to all the speakers. Thanks to Liz and Diamond, especially for sharing your very personal experiences and your very valued expertise and for the work that you do day in and day out. And thanks to everyone who came to listen.
Agreed. We will share the slides, the English recording, and the Spanish recording in follow-up. If you would like to connect with us, you can find us online. Again, thank you for your time. Hope that you have a lovely day. Thanks all. Andrea, will you stop the recording if you haven't already?